and the preliminary results of ICENS study, you can think that, okay, yeah, my disclosure, I am consultant for BAL company. So you can think that coming back to coiling in the era of flow diversion, state-assisted coiling, intrasaccular flow disruptor is a little bit strange, but we have to look at the place of coiling in aneurysm treatment. Is ARETA study, which was conducted in France to evaluate all endovascular treatment modalities and to evaluate the risk of aneurysm recanalization at 1 year. But what we see here in this global population, you see that we were including 1,358 aneurysm treated by endovascular approach. On what you see here, you see that the rate of aneurysm, the percentage of aneurysm treated by coiling is still completely high. You see that for ruptured aneurysm, okay, this series was inclusion were between 2013 and 2015. I agree that probably things changed since that recruitment period, but still, you see that at that time, the rate, the percentage of aneurysm treated with coils, either with coiling alone or balloon-assisted coiling, where for ruptured aneurysm, 97%, more than 98% of aneurysm, and for unruptured, still we had a very high percentage, close from 72, 73% of aneurysm. So in total, in the global population, you see that we still use at that time, but it's not so all time from now, but you see that we were treating 87%, more than 88% of aneurysm with coil. So coil are still useful for the treatment of aneurysm. You see that for a ruptured aneurysm, it was 98% of aneurysm. For unruptured aneurysm, 73% of them we are treated with coiling. In fact, I am not including in this also stent-assisted coiling on coils placed in association with flow diversion. So in fact, the percentage is probably higher, but whatever. Let's say that what is the first tool to treat the aneurysm, when it's the first tool for the treatment of aneurysm, coiling, it's 73% of unruptured aneurysm. So now Optima coil system, you know, Optima was coming after first generation, which was a barricade coil. You know, a barricade coil, it was an electrolytic detachment. Now the Optima coils, it's a thermal detachment. You see that the time to detach the barricade coil was 7 to 6 seconds, where now Optima coils, the detachment is less than 1 second. It's really instantaneous, so which is indeed important in the process of treating an aneurysm, singularly when the procedure is a little bit complicated. So pusher design, you know, it has a distal body coil on a proximal novel hypotube, which give a very good pushability and a very good distal softness. So it's a very useful coil for the treatment of aneurysm. And I have to accept that it's a first line coil we use in my department. You see the difference between the barricade coils for the pusher and the Optima coil. Okay, I already present this. So you have indeed a connector to make the thermal detachment of the coil. So you have a handle like any other coils, which is required for Optima coil detachment. Indeed, it's a handle that you can use for a single patient. It is good for 60 detachment cycles. So it means that theoretically you can use just one handle for per procedure. So Optima implant, you have a new implant portfolio with improved implant designed for a very optimal softness profile. You have indeed helical or complex. You have a large size offering, 1 millimeter to 24, and you have a new naming methodology with standard, soft, and super soft coils. So, and you see that the most important thing is softness. The two most important thing is the softness of the profile and the detachment, which is really instantaneous. So just to show you some example, here it's a ruptured ACOM aneurysm, a small one in a male, 49 years old. you see here the treatment of the aneurysm. We place some coils under balloon protection. You see the final control angiogram here with a complete aneurysm occlusion, and it's 12 months follow-up showing a stable occlusion, maybe a small ectasia here, but let's say that it's completely stable. Another example here, it's a ruptured PCOM in a female 79 years old. You see the PCOM aneurysm here with a daughter sac. You see the treatment, placement of coils in the aneurysm. It is a 12 months control angiogram showing a very good stability of aneurysm occlusion. It's a 3D DSA showing the stable aneurysm occlusion. Here, another example, you see it's a ruptured aneurysm of the MC, of the left MCA in a female 51. So we were discussing with the neurosurgeons. They were saying, okay, you have two lobules here. We are not completely aware if it's a single sac or two sacs on the same artery. So the neurosurgeon were saying, we will clip it. You see here the opening of the skull, the placement of the clip, and it's a final control. It's a control angiogram, and you see that we still have the aneurysm. So what we decided to do is to try, but you imagine that it's not simple. You have the clip here, the neck is wide, so you know that when you have the clip, it's really difficult to place, to deploy the coil because it's rigid, the clip is rigid. So we try first with a non-optimal coils. I will not say the name of the company, but whatever. And it was not possible to place the coil, and we were using optimal coils finally with a balloon remodeling technique, and we were able to place just one coil, but it's a final control angiogram showing a complete aneurysm occlusion. So it shows you how soft the coil is, and it shows you here the control angiogram showing a complete aneurysm occlusion. So the coil is soft, and it's sometimes very useful to have this type of coils. Here, another example, a ruptured basilar artery aneurysm. You see the bleeding here. You see the very strange shape of the aneurysm. What we were doing, we were placing, you see, more than we were expecting, 5 optimal coils. It's a final control angiogram. And it's a 12 months follow-up showing, you see the 12 months follow-up here, you see that we have a very good occlusion of the aneurysm sac. So other example here, unruptured aneurysm, female, 54, fortuitous aneurysm. So you see the aneurysm here. So what we were doing, we are using a balloon remodeling technique, placing several coils in the aneurysm sac. It is a final control angiogram. Here you see the 12 months control angiogram. You see the coils here and the coils here, and you see that the aneurysm is completely occluded and is completely stable. Multiple aneurysm, or you can also treat multiple aneurysm. You see here you have a patient with a ruptured pericallosal aneurysm and unruptured ECOM. So what we are doing here, we are treating the ruptured aneurysm first. It is a final control angiogram. We are treating the ECOM aneurysm in the same procedure by placing some coils in the aneurysm sac, and it's a final control angiogram, and it's a 12 months DSA follow-up showing complete aneurysm occlusion for both locations. Complication, indeed, we may have complication like with every kind of coils. It's unruptured ECOM aneurysm, and it's a 67 years old female. So we are placing a first optimal coils 4x13, but immediately after placement of the coil, we had this extravasation of contrast media showing that there is a rupture. What we were doing, we were reversing heparin very rapidly, and we were placing 3 more coils in. I checked with timing on the film, and we were seeing that there was 7 minutes before we were able to stop bleeding. It is a final control angiogram with a complete aneurysm occlusion. You see that there is no problem with the distal branches. It is a post-operative CT with a lot of contrast media in the subarachnoid space, but it is a 24-hour MRI in susceptibility-weighted imaging, showing very little bleeding in the subarachnoid space. And at 1 month, the patient was 0, and it is a 12 months DSA follow-up showing complete aneurysm occlusion. Just a few words regarding MRI artifacts. There was a problem with barricade coils because they were not the coils themselves, but the detachment zone was creating a lot of artifacts which make evaluation of aneurysm occlusion with MRI very difficult. And you see that now with the optimized coils, the detachment system is completely different. And you can see very clearly the status of aneurysm occlusion because you have very limited artifact related to the detachment zone. Just to show you an example, here is the same patient, but you see here the native slices showing this big artifact related to the detachment zone. Here it is the other case. You see that we see the coils in the aneurysm, but we also can analyze precisely the ICA and the PCOM. So INSTANCE study rapidly was conducted by me. The sample size was 300 patients. The goal was to evaluate the optimal system. It's a non-interventional prospective single-arm international multi-center study. There were 7 countries involved with 21 sites in Europe. The goal was to document safety and efficacy of the barricade coils, to describe the morbi-mortality, to describe the occlusion rate at 12 months, to document the technical features. So the primary endpoints were morbi-mortality at 30 days. And there were several secondary endpoints, including the post-procedure and the 12 months efficacy endpoint, which was indeed aneurysm occlusion. There was also an ancillary study dedicated to the evaluation of MRI artifacts. So there were really basic inclusion criteria, let's say aneurysms that can be treated by coils and singularly by Optima coils. There were some exclusion criteria, singularly a giant aneurysm on classic contraindication like aneurysm associated with arteriovenous malformation, dissecting or fusiform aneurysm. There was a core lab who was Phil White. There was a clinical event committee with Professor Denis Arbreteau and Dr. Anne-Christine Januel. And you see now the recruitment is completed with 300 patients enrolled by 13 of October last year. So we expect to have the last patient last visit in April 2022 and to have the first clinical study report in Q3 or Q4 2024. So what we had 70 European countries involved. So you know that the country we were enrolling a lot, indeed France, but also Spain and Latvia and Italy. So it's a list of the participating investigators in France and other countries. And here you see the distribution also by country. And you see the enrollment, and you see that the number of patients was limited to 50 per center. You see that the 2 centers that were including 50 patients were in France, Bordeaux and Lyon, with Professor Ecker, and Lyon with Bordeaux with Dr. Berge. So when we look at the demographic data we have for the time being, you see that as usual we have more females than male. When you look at the age category, nothing special. Again, the most frequent population is between 51 and 60. When you look at the aneurysm location, you see that the more frequent location was anterior communicating artery, followed by ICA, followed by MCA, followed by vertebrobasilar system. And when you look at the status at the baseline, you see that we have more or less 50-50 ruptured and unruptured, and we have 10% of recognized aneurysm. Finally, regarding aneurysm size, we have 10% of large aneurysm between 10 and 25. And you see that most aneurysm had a wide neck, 64% of aneurysm. So as of now, we don't have the clinical result and efficacy results indeed, but we will continue to evaluate the results. And the core lab is actually on the CEC are actually working to prepare the results of this study. So thank you for your attention.